Good evening, and welcome to this important broadcast. My name is Ellis Dean, and I'm the Director of Programming and Production at BlackDoctor.org. Tonight's program is titled We're Together, Redefining Fibroids and Endometriosis Care for Women. Now, let me tell you a secret. I'm a man, and I identify as such, so I don't know much about what it's like to experience fibroids and endometriosis, but I also consider myself an ally. And as an ally, I recognize there are significant disparities when it comes to the diagnosis and treatment of these conditions for women of color. I also recognize that these disparities can begin and end with the healthcare providers who are treating women of color for these conditions. That is what we are here to do tonight. We have assembled a panel of experts to help healthcare providers learn about the new guidelines, other options besides surgery, and engage in shared decision-making. We're doing this to improve outcomes, increase awareness, and create transformational advocacy. We're also doing this so we can move forward together. Let's begin. My first guest is Dr. Barbara Hanna, aka Dr. Bobby. Dr. Bobby is a board-certified obstetrician and gynecologist and is a physician and owner of Women's Center Healthcare Physicians in the Detroit area. Dr. Hanna made the decision to become a physician after teaching high school and middle school science, and also after obtaining graduate school degrees. Dr. Bobby is an author, educator, and fierce advocate for women's health. Dr. Bobby, welcome to the program.
Thank you. I'm very happy to be here.
My next guest is Dr. Taruba Prabhakar. I'm hoping I'm saying that right. As a board-certified OBGYN and minimally invasive surgeon, she helps women with fibroids live a life with reduced bleeding, pain, and improved fertility. In October 2023, she opened her own gynecology and surgery practice in the Bay Area, where she provides highly personalized, accessible care to women through all phases of life. She is able to provide care in creative ways in the office and via online coaching programs. She can be found on social media at the Fibroid Doc on Instagram and YouTube. Dr. Prabhakar, welcome to the program.
Thank you so much for having me. So excited to be here. And it's Dr. Prabhakar. Thank you.
Prabhakar, sorry, I knew
no problem.
I the tongue on that one. Okay.
Thank you.
Prabhakar, so I'm sorry. And my final guest is Marcy Fitzgerald. She is a certified nurse practitioner dedicated to improving the overall health and wellness of marginalized populations. At the Healthcare Connection, Marcy has demonstrated her commitment to ensuring each patient receives the highest quality healthcare. Her upbeat, energetic style allows her to connect with her patients and build trust in a unique way. This empowers each individual to actively take charge of their own health and employ behaviors which will help them achieve their best health outcomes. Welcome to the program, Marcy.
Thank you so much. Glad to be here.
Absolutely. So let's get right to the problem. Dr. Prabhakar, could you give us the statistics on Black women and fibroids?
Yes. So fibroids are a very common problem amongst many women. Up to 80% of women will be diagnosed with a fibroid by the time they get to be about 50 years of age. But Black women are disproportionately affected and have a higher incidence of having fibroids. So by the time they're age 50, 90% of Black women are diagnosed with a fibroid. And rolling back that statistic, by the time they're 25, 25% are diagnosed. So that's 1 out of every 4 women, Black women, by the time they're age 25, which is very, very common, way too common.
That's way too common, and that's right in childbearing ages. So
that's right, and it poses a lot of problems in that phase of life as well. And fibroids are a problem in themselves, but then add that to pregnancy, it can really create quite an issue for many women.
So, Dr. Bobby, if Black women are more likely to be diagnosed with fibroids, what could healthcare providers do to ensure their patients' treatment is both culturally competent and inclusive?
So that's a great question. So I believe that in order to treat a patient appropriately, the healthcare provider needs to know about fibroids. They need to educate themselves about the disease process itself. And remember that in a patient who is of African American descent, those patients, like Dr. Prabhakar said, have a very high chance of having uterine fibroids. So it's just keeping it in the back of their minds that this is a very high probable diagnosis. And the other thing is, it's important for healthcare providers, if they themselves don't actually take care of the uterine fibroids, have a referral network. Have someone that they can refer the patient to. And it's okay, not everyone feels comfortable taking care of uterine myomas or fibroids. So as long as you have a referral network, someone to send the patient to, and keeping your awareness high that this could be what the patient is suffering with, I think that can help tremendously.
Absolutely. Well, those are great tips. So, Dr. Prabhakar, what are some of the biggest challenges in the patient-provider relationship when it comes to the treatment of fibroids?
Yes. So as Dr. Bobby mentioned, the first is, the provider being aware of fibroids, and hopefully people are, but this is a diagnosis that does get missed. So not all patients present the same way. So some may present with bleeding, others may present with pelvic pressure, frequent urination, but a fibroid can cause all of these things. So being aware of the diagnosis and thinking about it actively, especially in a Black population, African American population, does help. Sorry, can you repeat the question once one more time? I was like lost
So,
my
what,
train of
what are
thought.
some of the challenges in that
Oh
patient-provider?
yeah, yes. The other thing that I was going to mention is time. Healthcare these days, is taken over by corporate entities. Appointments are 10 minutes long, 15 minutes long, and that's from the moment the patient, walks in to the moment the patient walks out. So with their actual provider, it's like 8-9 minutes. So imagine taking a history, really listening to the patient, coming up with a diagnosis, ordering the right test. I mean, that's a lot to do. So in my opinion, that's one of the biggest challenges. And so I encourage patients to try and do some work beforehand, and not play doctor, but try to educate yourself already on some of the things. We have excellent online resources before even seeing your provider. So you are very succinct about what it is you want to say. So I think the time is the biggest one. And, being educated is the second one.
So, Dr. Bobby, what role do the providers play in the creation of some of these challenges that Dr. Prabhakar just talked about, and more importantly, overcoming them?
Probably one of the biggest roles that they play is not being able to make the diagnosis, and or not having a referral network to refer the patient to. It's really important that healthcare providers realize that uterine myomas plague up to 80 to 90% of women of color. And keeping that in the back of their minds when they're making the diagnosis or when they're seeing the patient is very, very important.
Absolutely. So, Marcy, I'm gonna come to you. As a nurse practitioner, you are in that role a lot in terms of meeting with the patients. But sometimes patients feel more comfortable talking to you than they do to, that white coat syndrome can come into play. And even sometimes when you walk in with a white coat, what are some of the things that you do to kind of help ease that relationship to make it better and make them open up more, even in that shortened amount of time that Dr. Prabhakar was talking about?
Very, very good question, and something that I encounter because I am practicing in a federally qualified health center. So I see the marginalized population, the underserved population. Often my patients are patients of color. One thing for me, I don't wear my lab coat. I just don't, and that is probably more a personal preference. But I think maybe traditionally, if I step back a little bit before becoming a nurse practitioner and being an ICU nurse, I think a lot of that comfort level with the nurse is based on time spent, right? In the hospital, they spend a lot more time with the nurse. So there's an opportunity, a greater opportunity to develop a relationship and a trusting relationship that would translate into a therapeutic relationship. But jumping forward, as Dr. Prabhakar said, that I got the same 15 minutes as everybody else, and it's hard. It's hard, but one is walking in there with empathy, just as a frame of reference. Um, that people use when they're coming to see us, they're scared because there's something going on that they don't know what is happening. So understanding when they walk in the door, they're there for help, but there's trepidation there. And as Dr. Bobby said, understanding the patient population, so knowing the epidemiology and understanding how often fibroids impact African American women, knowing that needs to be top of mind, right, in your decision tree, in your differential diagnosis. And I think approaching the patient with that empathy and trying to meet them where they are. And they come to us with varying degrees of health literacy, lots of socioeconomic challenges, health history. Sometimes they don't know their health history, their family history, or what have you. So there's a lot to smash into that 8 or 9 minutes. But kind of having that list and understanding that in the back of your head. And I would say explaining in that, I think we'll probably get into this later, in a way that they can understand. I think that the onus is on us, right? We have the knowledge, we have the understanding. The onus is on us to translate that because the goal is for them to have the best outcome, right? So that I think that's that, and trying not to be impatient, because I know we're looking at that list and like that one turned red, that one turned red. I got 5 people waiting, and you're trying to get in and out of there. But making them feel comfortable, I think, allows them to open up and give us more of the history and the symptoms that we actually need to make that diagnosis, to order the right tests, and to make the appropriate referrals. Because rushing is we're going to miss stuff, and that can be detrimental to our patient outcomes. So I think we all have the same goal in mind, and that's how I try to approach it.
That's great. That's fantastic. So, Dr. Prabhakar, there are some disturbing statistics regarding the overuse of hysterectomies as treatment for fibroids in women of color. Why do you think providers are choosing hysterectomies instead of other proven methodologies of treatment?
Yes. So, in the US, there are about 600,000 hysterectomies every year. And about 42% of those, so about 60% of those, in a recent study in 2015 and 2018 said, were quote unquote unnecessary. So what does that mean? That means a lot of women are getting hysterectomies for abnormal bleeding, for fibroids, when other treatment options could have been offered. And I think, medicine is rapidly changing, and there's only so much that, residency can teach you, that fellowship can teach you. And I think providers are a little afraid to refer appropriately. As Dr. Bobby had mentioned before, it is so important to have that network. As OBGYNs, a lot of OBGYNs practice obstetrics, which is all the delivering babies part, and then gynecology, which is all the other female health related, diseases and surgeries. And it's hard to master both. In my practice, I focus, for example, only on gynecology and surgery. And so if you're an obstetrician who spends 60 to 70% delivering babies, guess what? You really don't have that time to be on top of all the latest treatments. And every year we are getting new guidelines and new treatments that are coming up, which are fabulous. But if you are not on top of the latest guidelines, you don't feel comfortable prescribing them, then you're just going to, default to your old patterns, one of which may be a hysterectomy. But we know that that is not the first line for treatment for fibroids today. And I think this is where the biggest problem lies, really, is just the lack of training, or just the time constraints, and kind of the maybe embarrassment or whatever it is to refer appropriately to those who do this all the time. Because I really do believe when a patient goes to a specialist, a fibroid specialist, then that specialist knows the lifestyle modifications that can be done that are the latest and evidence-based, the medications that are evidence-based, and then, you know what, if those don't work, maybe some minor procedures that come next, and finally the hysterectomy. And I really think the hysterectomy does have a place for some women who have very large fibroids that are potentially malignant, or that, you know, are really not amenable to other treatment. But there are so many treatment options in our arsenal today. And so my biggest message to patients is, before you go to see somebody for your fibroid treatment, research them and make sure that they are a specialist in that particular field, or they practice a lot of gynecology, or if they are both OB and GYN, that they actually like surgery and that they are up to date on the latest managements. And when I say like surgery, that means a lot of surgeons, though, are also constantly keeping up on the medical management.
Well, that was a fantastic answer. I'm sorry. I didn't say that. It was really, really good, and a lot of information in there. So I'm going to summarize it. So do your research on your provider. I think from a provider standpoint, if you're not comfortable handling that part of it, have a referral. As Dr. Bobby said, have a good referral and be okay with that, right? So sometimes, I'll say ego can get in the way and you want to treat your patient. But sometimes you might just need to refer them out to somebody that's more equipped to deal with that. And it's very important. Patients have to do the work on their end. And luckily there's devices in all kinds of ways that we can do our research on a particular provider, that we can get that information to feel comfortable before we even step into their office. So Marcy, there is a catchphrase, now, and I think you touched on it a little bit in your answer, and we hear it all the time, and I think I even said it earlier: cultural competence. When you hear that, what does that mean to you, and how can providers show to their patients of color that they have a certain degree of cultural competence?
Great question. So cultural competence is basically the ability to deliver appropriate care that is culturally sensitive, because our patients have different backgrounds, different beliefs, different values, lots of different things that are tied to their specific culture. And it does our patients a disservice if we treat them as a monolith, right? So it is the ability to, one, I think we have to start with awareness that there are different cultures that will impact how patients will evaluate treatment options and understand their symptoms and understand the different treatment plans, and how we kind of present what that looks like to them. And without, I think, just going back and doing the work yourself.
Yeah.
It's a lot of self stuff, and we have to kind of make sure that we're not skittish about it, because not being culturally competent, we're going to provide suboptimal care. There's no way really around it. So I think we have to be aware of it. And each day, sometimes we're going to get it wrong. So we can't be afraid to get it wrong. But I think just making sure that the patient knows that you really are giving it an effort, and you're trying to meet them where they are, from the cultural side, from the health literacy side, from where they present symptom wise. I think just presenting that effort, that you're trying to give them the best options for them to choose from. Because some you can't tell them what to do either. So be careful, tread lightly. But I really believe that is the biggest thing. It starts with awareness, and then an intentional effort to understand as much as you can understand. You can't know everything about every culture and every health condition and all of that, and how they will view your advice and your treatment, but as much as you can. as much as you can incorporate that in your practice and make it intentional and not as an afterthought.
Dr. Bobby, same question.
Yes, I think that's a great answer, Marcy. In our society, we have tried so hard to mainstream everyone, and we are forgetting that there are differences in people. And I believe the best way to do this is to celebrate those differences. If I have a patient who I know would not want surgery, or a patient who wants her husband to be in the room, like Marcy said, at least make the attempt. Now, we're never going to know everything that there is about everyone's culture, and we're not required to. But if we just know a little bit and make an attempt to respect that culture, it makes all the difference in the world. And patients see us as being much more sensitive to their needs.
Absolutely. Dr. Prabhakar, do you have anything you want to add on that?
Yeah, I was just going to say, in medicine, we see this all the time. When a South Asian patient comes to me and talks to me about diabetes, I know that half their plate is full of rice and rotis, like I know that already, and I'm already anticipating that and giving them tips on what else they could, what else can they eat that's still, within our cultural, milieu, that will help them with diabetes. Or when a patient from Brazil is insisting that she has a C-section, right? Because that's just, very common in Brazil, and that's just part of the culture. Whereas in Berkeley, California, where I live, that is, totally not part of the culture. So instead of strong-handing someone into doing, what, we think should be mainstream, giving them the risks, the benefits, giving them the options, but still letting them choose, I think is a cultural competent way to approach our healthcare.
I agree.
Absolutely. So, Dr. Bobby, I know we're talking about fibroids, and if you're just joining us, we are talking about Forward Together. We're trying to redefine fibroids and endometriosis care for women, particularly women of color. So, Dr. Bobby, could you provide some statistics on Black women and endometriosis?
Yes. So traditionally, Black women have been thought to have very little endometriosis. That was not seen as a common problem in Black women. So let's just start with the incidence of endometriosis in this country, and actually globally, is about 10 to 15%. And there was quite a bit of bias in the literature based upon some erroneous studies that said that Black women likely did not get endometriosis. And I was even taught that during my residency, and I finished my residency in 1998. But in the 1970s, there was an attempt to reevaluate those statistics, and it became common knowledge that Black women do indeed have endometriosis. And oftentimes those diagnoses associated with pelvic pain and thought to be pelvic inflammatory disease or PID, which a lot of times African American women are labeled with, actually turned out to be endometriosis. And just as an FYI, endometriosis is what we call ectopic endometrium. So that means the lining of the uterus, which is normally shed once a month, ends up inside the pelvic cavity. It can end up inside the upper abdominal cavity, in the lungs, on the diaphragm. So this endometriosis is quite painful. And patients who have endometriosis can often have some issues with infertility. So another factor that's mind-boggling to me is that it can take up to 7 years for a patient to get the diagnosis of endometriosis. She'll go from provider to provider, and it's not for 7 years. And those are years which are high in her reproductive capability. She's
Yeah.
losing that because the diagnosis has not been made.
Wow, that is some disturbing. Yeah, wow. Okay, that's why we're having this discussion. So, Dr. Prabhakar, are there differences in how Black women presenting with endometriosis symptoms are diagnosed and treated? And if so, what are those differences?
I think one of the challenges for in the treatment and the diagnosis of endometriosis is that it is a surgical diagnosis, and I think this point is vastly underestimated by both physicians and patients.
Mhm.
So, which means that you can kind of guess that somebody has endometriosis based on their presentation. You can give them the birth control pill. You can do all those things. But until you take them to surgery and put in a camera into the belly and take a biopsy, you did not have the diagnosis of endometriosis. And so the faster you do that, the better, because once you've diagnosed it, then you can proceed with all of the treatments. So physicians often, as I previously mentioned, some just may not operate a lot. They don't feel comfortable. So they just kind of, giving the patient medications instead of saying, hey, you know what, we need to go to the operating room and just get this sorted out. On the flip side, patients often view surgery as something, oh, really, like, let's try to avoid it at all costs. And I'm all one for, conservative management. We try to do the least invasive thing first. But again, this particular disease, endometriosis, is the gold standard, is surgical diagnosis. And so learning that, I've been going to all these doctors for all these years, I'm given all these pills, I'm still having pelvic pain, I just need that laparoscopy. So I think we need to approach it from a patient perspective and a physician perspective. And I think this really causes much of the delay. Now, in specific, particularly about Black women, I've not seen recent studies that show the difference in statistics. As Dr. Bobby mentioned, there's about 7 million cases of endometriosis per year in the US, and it takes 7 years to actually get that diagnosis for all comers. And
Wow.
I think the sooner we understand that this particular disease, unlike fibroids, once we get that, we can just do an ultrasound and it's not very invasive, and we get the diagnosis. That diagnosis cannot be really achieved through imaging for endometriosis. And I think that is one of the bottlenecks of diagnosis.
Right, right. And I think maybe some of the just spitballing, and Dr. Bobby and Marcy, y'all can correct me if I'm wrong on this one, is that Black women presenting with pain typically are dismissed at a higher rate. And so if you have endometriosis presenting with pain, they might say, oh, it's stress. They may label it something else, and then they get dismissed and giving a light painkiller, and then they have to either not go back or they go to another provider. So that could be contributing to some of the challenges that Black women are facing.
Yes, that's right. There was actually a New York Times article about medical gaslighting this year. And so a lot of women compared to men, a lot of our symptoms are not taken seriously. And then add on to that layer, women of color, we definitely have a bigger hurdle there to jump.
Absolutely. Absolutely. Okay. So, wow. I mean, this is really some great information that you all are providing. So, Dr. Bobby, how can some healthcare providers, I'm trying to ask this the right way, how can healthcare providers recognize their bias when it comes to treatment of patients of color versus white patients? And are there some things that patients can look for when presenting for treatment that might suggest, hey, this person is not as competent, or they may have some biases against me?
That's a tough one, Ellis.
Yeah.
I think that it requires some soul searching and some admittance on our part, and to realize that we all have biases about one thing or another, and to admit to yourself that you have that bias. And I don't believe it's a problem that can be addressed in any kind of fashion until a person actually can admit, yeah, I do have that bias. And it's painful. It's painful to admit to yourself that you may see a patient one way and see another patient another way. So I believe it's just being honest with oneself. And then I know of classes and programs that can be helpful. Most hospitals have some kind of diversity, equity, and inclusion program that welcomes providers to come and to discuss things openly and honestly. So I believe we have to first admit our biases before we can fix them. Once we fix them and have admitted them to ourselves, then we begin to see patients in a different light. Then we can start rendering different kinds of healthcare, more quality healthcare.
Marcy, I see you shaking your head. Are you agreeing? And
Well, absolutely. And on an individual level, absolutely that. And I think from an organizational level, step back to my business background, the organization has to be very clear that it's a priority,
Mhm.
and there can't be any kind of retaliation for somebody admitting that they have a bias, because people will shut that down, and they won't admit it, and we won't be able to move forward. So in addition to the individual, making sure that the organization has it as a priority, and like you said, there are many, and most organizations these days do have some sort of DEI work, or the diversity, equity, and inclusion work going on. And if you continually tie that to your measures, then you usually will get more attention to it. So I just wanted to throw that in from an organizational context.
no, that makes perfect sense. So, Dr. Prabhakar, we've been talking about this a little bit tonight, and so we're going to get right to it. What are some of the alternative treatments for fibroids that do not include surgery?
Yes, so I like to think about it in a few different buckets. So the first is lifestyle modifications, and that really comes down mainly to diet. Now, I wish we knew that there was a magic vegetable that we could eat that would take away or shrink fibroids, but at this time, we haven't come up on that yet. But there was a large study from China that shows that increasing cruciferous vegetables such as cauliflower and broccoli can help. So that's what I tell my patients. I do recommend a plant forward diet. So at least trying to be 80% plant based can really help with just decreasing inflammation, and eating a lot of fruits and berries to improve your antioxidants. All of that can definitely help. Exercise, detoxing in general from harmful substances such as alcohol, cigarettes, all of the things that are helpful for pretty much our entire body, not just fibroids. But this portion is one of the things that is most overlooked. Often patients are looking for a quick drug, a quick thing, but unfortunately, the majority of the work is slow and steady. So that's the first thing. The second thing is the medication bucket, and there is a lot. And I won't go into too much detail. I'll just mention some of the names so that patient, whoever's watching can look it up. There's the birth control pills. There's the Mirena IUD. There's progesterone only pills. There's Nexplanon. There's Depo-Provera. There's Lupron, and more recently there is Orion for decreasing bleeding from fibroids, and there's Myfembree. So these are some of the latest and greatest developments in medications that we offer patients. And so it also really depends on what the symptoms are. So if your symptoms are more bleeding, then probably the medications are more likely to work, versus if your symptoms are bulk, like you look like you are 6 months pregnant, then they are probably less likely to work compared to surgical alternatives. So it also depends what the symptoms are. But I think the foundation should be the healthy diet and lifestyle. Starting off, especially if you have a family history of fibroids, your mom has had fibroids, your grandmother, your auntie, then these are some things. It's hard sometimes to reverse those cultural and familial trends of what we eat, and but this is the time to really evaluate that. Even if you're in your early 20s, this is the perfect time to look at that. And then, of course, there are surgical options.
Dr. Bobby, any other treatments you want to add to that, or was that a pretty exhaustive list?
That was quite exhaustive, Dr. Prabhakar. But I just wanted to mention that cruciferous vegetables are beginning to have a role now. And we are realizing that there are other diseases that cruciferous vegetables can help with. For example, women who eat cruciferous vegetables have fewer instances of breast cancer. So that's maybe for our next talk. But the broccoli, cauliflower, kale greens are helpful in other areas other than uterine fibroids.
Wow. So my mother forcing my sisters to eat that really helped them grow.
Right.
That's right.
Exactly.
All right. So I'll call her and apologize after the program. Um, so, Dr. Bobby, sticking with you, what are some current strategies being implemented that have been effective in improving that patient-provider relationship? Because, and let me give you some context. And Marcy, I want you to answer on this one as well. Is there has been kind of a push now, not even a push, but a movement in terms of getting a shared decision-making model, developing a shared decision-making model between the provider and patient. Because traditionally it was, I present with some symptoms, you run some tests, you come back and you say, here's what it is, here's your treatment plan, and that's it. Now it's trying in that shared decision-making model, it's like, okay, here's what we found, here's some options for you, and here's, and then the patient becomes part of that decision making before a treatment plan is handed out. How effective, or do you see this as kind of the new wave and the more important and more effective way of providers to interact with their patients?
Absolutely. And I can't imagine it any other way, Ellis. I mean, I'm there for the patient. I'm there to take care of the patient. And she has a role in her healthcare. In fact, she has a bigger role in her healthcare than I do. So I can't imagine a provider coming along and saying, we're going to do A, B, C, and D, and that's it, without any kind of patient input. Vast majority of patients in my office, I hope, feel that Dr. Bobby has given me the opportunity to be a part of my healthcare, because that's why I'm there, to provide healthcare for them. And I need and want their input. So that's just hugely important, that the patient is a part of her healthcare and that she helps to make the decisions about her healthcare. And then once the patient feels like she's making the decisions, then she's going to be more amenable to making those changes to better her health.
Mm.
I completely agree with Dr. Bobby. And I guess in the past, it may have been easier to have that model where providers would provide, you get the symptoms, you provide what the treatment plan is, and you give the patient their marching orders. But today there's not that asymmetry of information, right? There's so much more information out there, and that they come to you with a lot more questions, and what about this and what about that? So you almost have to employ shared decision making. And I think it goes back to my earlier point about building trust. So they feel more a part of that decision making, and they are more likely, I think, to trust the provider that is laying out that information. We have maybe more access to what is the most up-to-date treatment and therapies and the evidence behind that, and we can provide information on the options with that kind of data, but giving them those options, again, in a way they can understand it, in a culturally sensitive manner that takes into account a lot of the filters that they're going to receive that information through, and then allow them to make the best decision for them with all of that. I think allows for better outcomes, just as Dr. Bobby said. If they feel invested in the treatment decision, they're much more likely, like you said, to be adherent and even proactive about implementing a treatment plan.
Dr. Prabhakar, do you have any examples of where a shared decision making that you had proved to be, productive in terms of developing that trust relationship that Marcy is referring to and having a better outcome for your patient?
Yeah, I think when we talk about that, it really comes down to trust. I'm a minimally invasive surgeon, so even though I'm a surgeon, I start with the most conservative option for fibroids. When patients come into my office, I start with the diet, and then move on to all the medications that I mentioned, and then finally we come to surgery. And I've had patients who, even though in my mind, they have a belly that's like a 7-month-old pregnancy, and I'm like, my mind, they really just need that hysterectomy, but I allow them to go through all of the motions and all of the medications that they want to try and that they feel comfortable with. And at the end, the patient feels comfortable making that decision. You know what? I do need that hysterectomy. And so I think it goes a long way in building the trust. It ensures that the patient has feels like she has made the right decision, and that's hugely important, rather than feeling like, oh, someone just forced me to do X, Y, or Z. And from a patient perspective, I belonged to a big practice a few years ago. There was about 11 people. And I asked a patient, how did you end up picking me out of this big group? And she said, well, you're the only woman of color. And I thought that was a little weird at that point. But now it makes perfect sense. So, from a patient perspective, if you find a provider that is more like you, either in language or how they look or whatever it is, feel free to pick that provider. I think if I'm a Latina woman and my doctor is speaking fluent Spanish, maybe that gives me an extra sense and a level of comfort. And there's nothing wrong in that. We know that there are different kinds of bonds that are formed here, and that also, I think, goes a long way in the shared decision making process. And both parties may sometimes just feel more comfortable, and there's that extra level of trust.
So, Dr. Bobby, I'm gonna address one of the elephants in the room. When Black women tend to start to advocate for themselves, uh, there's a bias that can say they come across as angry or hostile. How do we overcome that kind of narrative about Black women that advocate for themselves so we can get to the point to where they're really just trying to speak on their behalf, and they could be speaking from that past experiences that were not as positive when it comes to engaging in healthcare. And so they're coming in ready for a fight. And how do we get the patient to recognize, okay, every situation is unique? And how do we get the doctors to recognize that if a patient comes in and they are aggressive and ready for that fight, how do they quickly disarm them and not get into the situation where it becomes hostile and nobody is served?
So that's a great question, Ellis. It's a tough question too. Every patient who walks in that door has had some kind of experience, positive or negative, before they walk into the office. Everyone. So I believe that it's really incumbent upon us as providers to be in tune to just any and everything. If a patient cowers when she's having a pelvic exam, for example, you may think, well, maybe there's been a history of some type of sexual molestation. Be sensitive to that. It's up to us to pick up on cues. Sometimes they're very, very small cues that a patient may exude. And it's up to us to pay attention to those cues, whatever they are. And again, there may be that patient who comes in angry and upset about something, not necessarily something that happened in my office, but they're bringing some hostility from a previous situation. Well, I had a situation not too long ago where I spoke to a lady about it. And after we talked for about 10 or 15 minutes, her anger was diffused. And I later found out that she had been to 2 or 3 different providers, and they had just dismissed her concerns and told her that in so many words, you're a Black female and you're angry, you're upset, and I can't do anything for you. So it is incumbent upon us to the nth degree to pick up on those cues and realize that there's usually something underlying those things and not to take it personally. She's had experiences, good and bad, before she reached my office. So I have to realize it's not personal, it's not directed at me, it's based upon some negative experiences that she's had. And I've got to recognize that.
Yeah. Dr. Prabhakar, I see you shaking your head. How do you do that in 9 minutes?
Yeah, that's, a couple of phrases that I like to use are, hey, we're in this together.
Okay.
That right away, I think lets the patient know or see that, okay, regardless of what has happened to me elsewhere, this doctor seems like she's listening to you. And I also say, what are your goals? I think sometimes women, as we've been discussing, especially women of color, feel dismissed. Oh, this is all part of getting older. This is all part of menopause. This is all part of this or that, rather than really individualizing our symptoms and our complaints. So saying, hey, I'm here for you. We're in this together. What are your goals? These are some of the phrases that I like to use in just getting to diffuse the situation and really getting to the bottom of the problem and taking care of the patient.
Go ahead, Marcy.
Just to add on to that, just very briefly, I let them know when we shut the door, it's a no judgment zone. I do not care where we start, just that we start. And they're here for something. There is a concern. It does not matter to me how you got there. I don't feel like you did something wrong. I don't want them to feel like they did something wrong, because then again, they shut down. They don't want to tell you the truth. And if you don't get the truth, you can't progress positively. So I often just tell them this space, this is your space to get better. No matter what the condition is, no matter what the complaint is, no matter what precipitated it. I don't care if you backslid, you stopped taking your meds, what that is. Today we're starting from here and we're moving forward. And hopefully, I guess, with them feeling that there's not any judgment, they're able to again reestablish trust, open up no matter what, and we can move forward. So that's how I try to address it.
So in that, Marcy, how do we help patients? Speaking directly to patients, what are some things they can do to advocate for themselves in a positive way?
What I encourage them to do first and foremost is just tell the truth. Say what they're looking for. It is hard in 9 minutes. For sure, it's very hard, and I often run behind because it doesn't take 9 minutes. So I'm usually running late, but it's always worth it. It's always worth it. I feel like we get better outcomes that way. But I encourage them, if they are not feeling like they are getting results, if they do not feel like it is going in the right direction, come back. Let's talk about it again. Let's see what interventions you've implemented. Let's see what's going on. Let's reassess. And that I'll fight for them as long as they're fighting for them. That if they don't give up on me, I'm not going to give up on them. And that includes, again, now I refer very liberally. I don't like to extend time to appropriate diagnosis and treatment, for sure. So I don't want anybody to misunderstand that. That is part of the care and that's part of the appropriate treatment plan. But if we're going down a path and you don't feel like it's satisfactory, tell me first. And give me a chance to try and address it satisfactorily so that you feel better. And no matter if it doesn't matter if it's going to hurt my feelings or if I'm gonna be sad it didn't work, none of that is important. At the end of the day, it is all about them progressing toward their optimal health status. So I try and make sure that they understand from A to Z in every single encounter that it is about them and them moving positively down that health continuum.
Dr. Prabhakar, same question. How can patients better advocate for themselves to where they can almost help you in that 9 minute if they come in prepared, ready to go?
Yes. So one of the biggest things I tell patients is before you make an appointment for the issue that you are looking to address, just do your research. Don't make the first appointment with, if you have fibroids, or endometriosis, don't make the first appointment that you see, coming through. Do some research, try to find out who specializes in that, so you can save time. Because often what happens is the patient will see their primary care doctor, will say you need a gynecologist, they'll go see a gynecologist, then they'll see like the PA at the gynecologist's office, and they'll say, oh, you know what, but I don't know all the treatments, you need to see one of the other doctors. And by the time the patient actually gets a diagnosis, even though they are trying, it's been 9 months. And so the best way to advocate for yourself is that first, couple of appointments, just make sure it's already, there with somebody who can answer all your questions and who can give you all the options for treatment, or somebody at least in that office. Second, write down your questions so that you're not getting there and then you forgot something really important. You just tell your provider, here are the 7 questions I have. And often they can tie all of that in together in a nice way in that short time. So you are actually leaving with, all of your questions answered. So those are my 2 biggest tips for advocating for yourself.
And Dr. Bobby, any patient advocacy, how they can advocate for themselves?
So I agree with both Marcy and Dr. Prabhakar that trust is super important, because the patient has got to have some degree of trust when she's speaking to you. Hopefully over time that trust grows. The more you speak to her, the more you let her see who you are. She feels more comfortable with you. So trust and being truthful are just huge components. And it's also important that the patient has done her research. And she may have her questions written down, and we might not get to all 7. We may get to 4 that day. But like Marcy said, there's always another day. If you come back another day, we can get to the other 3 questions, because, like we said, in 9 minutes, you might not be able to get to 7 questions.
Right.
But at least give the patient the opportunity to address what's most important to her. So I'll say, of these 7 concerns that you have today, what are the 2 that are most pressing and most important? We'll get to those 2 today. And
Right.
then at another time, we'll get to the other 5.
Gotcha.
I just wanted to add really quickly, my 3rd tip is don't be afraid to get a second opinion. Sometimes patients come to me for a surgical consult. I tell them what I think, and then they say, you know what, do you mind? They're embarrassed, or they think I'm going to be offended if they say, if they want to go see another doctor just to get a second opinion. And I say that's the best thing you can do, because you should feel really comfortable before you make a final decision on anything that you've sought out a couple of opinions. So I always encourage patients to seek out a second opinion if you're having questions, if you're not sure that that's the way you want to go. Just hearing from another perspective and hearing from another voice sometimes clarifies things for you.
It's good. Those are all fantastic tips. I know it's got a little bit of time. This flown by. This hour has flown by. So what are some resources that doctors or patients can go to in terms of getting more information about fibroids or endometriosis? Anybody can jump in on that. I didn't throw it to somebody.
There's the Fibroid Foundation, the American College of OBGYN, ACOG.org, the Uterine Health Guide, which is a great one, not just for fibroids, but for endo and heavy menstrual bleeding. So those are some of the top ones that I would recommend.
Marcy or Dr. Bobby, do you have any other resources that we could share with our viewers?
I like the Uterine Health Guide. That's been very helpful.
Well, we have it displayed here. So for those healthcare providers that are watching as well, you can share this with your patients, uterinehealthguide.com. And full disclosure, I was so happy with myself. I spelled uterine right the first time I typed it in. So, but yeah, so uterinehealthguide.com is a fantastic way. And as you can see, it's very colorful. It's very easy to understand for both patients and providers to give some health tips about fibroids and endometriosis and everything associated with uterine. So that is a fantastic tool to use there. All right, so we are getting very close to the end of our time. So we're going to wrap up. We're going to go around, kind of give your final thoughts, kind of put a bow on this discussion tonight. When we're talking about fibroids and endometriosis, and really in the bigger thing in terms of shared decision making, different treatment options available, just whatever is on your heart to wrap up. So we'll start at the top. Dr. Bobby, final thoughts.
So I would say to any patient, please be your best healthcare advocate. Be knowledgeable, do your research on different topics so that when you come to the provider, you are aware of some of the basic things, and know yourself. Know yourself and be very honest and truthful with your provider, because that gives us all the ammunition that we need to help get her where she needs to be on her healthcare journey.
Dr. Prabhakar?
Yeah, those were my thoughts, pretty much exactly. I think being the best healthcare advocate, you are your best healthcare advocate. And when we do research, just be mindful of where you're researching. There's a lot of fake news out there, as well, even on social media, where I know a lot of us like to get information, but just looking at the source of that, I think, is really critical. So you don't go down a rabbit hole spending lots of time, energy, and money on things that are not really evidence-based.
And Marcy?
And I would say the biggest thing, don't wait. And maybe that is a function of kind of the area that I practice in. So sometimes the patients are fearful for lack of understanding and will wait until symptoms progress, thinking that, well, it's just kind of how it is, or it's just the normal thing. So at the very least, initiate contact in a primary care setting if you don't have a specialist or what have you, to at least get the ball rolling. And once that is done, be diligent and follow up. There have been many times, like I said, I refer liberally, that I'll call and check back up, and the referral hasn't been completed. They haven't gone. I'm like, oh no, they're still suffering. No. So one, initiate that first contact to get your symptoms taken care of, and be diligent and follow up with your advocacy.
Absolutely. That's all great advice. I will want to point out that we did have a patient, a fibroids patient, scheduled to appear with us this evening, but unfortunately she was not feeling well. So I want to give a shout out to Coach Jessie, and wish her and all the prayers for a speedy recovery. We really could have used her voice here tonight, and so, but you all did admirably. In terms of final things, I would say to the providers, we had some great information here tonight for you. One, know what you don't know, right? In terms of your cultural competence and your biases, go in there. Then the more transparency, the more open you can be with your patient, the more quickly you're going to be able to establish the trust that we've been talking about tonight. Number two, learn what you can and know where those blind spots are. As Dr. Bobby talked about, she was trained one way in 1998, but things have changed, and it's always evolving. Try to stay on what you can stay on, but also be able to refer liberally, as Marcy talked about, if there's something that you're not fully comfortable with. Also, make sure that when we're talking about dealing with your patient, yes, there are limitations, and I want to thank Alicia for her comment, really just kind of praising you all for being able to do what you do in 9 minutes, but understanding that if you can build that trust, even if you can't address everything in that short amount of time, they'll come back. And what we really want is, to Marcy's point, we really want patients coming back and trusting you and feeling satisfied, even if they didn't answer all 7 of those questions on that first visit. So there's a lot more that we can discuss, but we're going to shut it down here. Thank you all. I'm sorry we weren't able to get to audience questions. We will get to that next time. We got more programs like this planned. I want to thank our partners at Myovant for sponsoring this. And they didn't want us to, they said, look, we just want to do patient education and talk to healthcare providers to increase that shared decision-making model and get to transformational advocacy. And that's what we're trying to do. But we can only do that by moving forward together. Thank you and have a good evening.
Thank you.